So my name's Ferrah Choudhary. I'm consultant interventional cardiologist and the PFO service lead at Manchester University Hospital's NHS Foundation Trust. So I'm going to talk to you today a bit about PFO closure and the evidence behind it and some of the guidelines as well. So we'll move on to my next slide. So as most of you will know, the Foramen Ovale is a small tunnel which allows blood to flow between the two atria whilst the fetus is in the womb. And usually this closes shortly after birth when baby takes their first breath. But in about a quarter to a third of people, it remains open or patent. And usually this is of no clinical significance, except, as most of you will know, in some cases where it can be defined as the etiology for cryptogenic stroke. Next slide, please. So looking through the evidence that we have, we know that there are over 100,000 strokes each year, of which 85% of it are ischemic, and 15 to 20% of those occur in people under the age of 60 years. And this information is from the Stroke Association. Now, PFO is the most common association in patients with cryptogenic stroke who are younger than 55 years old. And recent publications of long-term outcomes from RCTs that are available now provide a much firmer basis for the evaluation of potential treatment benefits, including PFO closure and antiplatelet therapy. Next slide, please. So the first lot of evidence that I'm going to talk to you about is this Gore reduced trial, because this is essentially what changed the guidelines for us. And it's quite a landmark trial. If we go to the next slide. So basically this study enrolled 664 patients, of which 81% had a moderate or large shunt, and they were followed up for 3.2 years. They were assigned randomly in one-to-one fashion to a PFO plus antiplatelet group or antiplatelet therapy alone. And you can see from the table the baseline demographics in that 60% of patients were male, in an average of 60% in both arms. They did have comorbidities, but to quite a low degree of, 4% diabetes, 25 to 26% hypertension, and then there was a small kind of 11 to 14% of patients that were smokers. The majority had ischemic strokes with symptoms lasting more than 24 hours. But there were some patients included, around 10%, who had had symptoms lasting less than 24 hours, but importantly did have imaging confirmation of an infarct. And the only other thing to mention is that about 20% in the PFO closure group have had an atrial septal aneurysm. And that's important because having an atrial septal aneurysm is thought to be high risk anatomy for paradoxical embolus. Okay, next slide, please. So talking through the results, I mean, you can see the graph here. I don't know if it's a bit blurry for you as well, but there was a significant difference with a p-value of 0.002 in the probability of freedom from recurrent stroke between the PFO closure group and the antiplatelet group. So basically, in the PFO closure group, the incidence of new brain infarcts were lower than in the antiplatelet group alone. So you had an incidence of about 18 patients versus 19 patients, but the incidence of silent brain infarcts didn't differ between the two groups. So that's important. Serious adverse events were greater in the PFO closure group, and we expect that because obviously that's the procedural arm, and so they are going to get procedural related complications. And usually those are related to vascular access, but also the occurrence of atrial fibrillation. Yeah, so this was the endpoints that I've just explained to you, and that there was significant differences in the ischemic stroke rates and new brain infarct rates, but not so much in the silent brain infarcts. So if you continue on. So you can see from this slides that they kind of implied that PFO closure plus antiplatelet therapy was better in younger patients who are male and who have a moderate to large shunt size. Next slide, please. And as I said, serious adverse events were greater in the device group, and also they were mostly related to the occurrence of procedural related complications from vascular access or the atrial fibrillation. You can see a rate of approximately 6.6% in the procedural arm. Next slide, please. So they concluded that patients with a PFO who had a cryptogenic stroke, that the risk of subsequent ischemic stroke was lower in those that underwent PFO closure combined with antiplatelet therapy. However, PFO closure was associated with higher rates of device-related complications and atrial fibrillation. Next slide. So there's two other studies that have been of similar volume and that have also kind of shown similar results. And the RESPECT trial, which looked at a variety of devices, so included Gore, St. Jude and Abbott devices. And then this French ministry study called CLOSE. You can see that there's good numbers in all three studies, ranging from 980 to 664, and they spanned a good amount of follow-up, up to 112 months in the RESPECT. Now, the differences in the randomization, you'll see that in the RESPECT arm, it was 1-to-1 Amplatzer PFO occluder versus guideline medical therapy. But in the others, there was a variety. And in the CLOSE study, importantly, they also looked at just the anticoagulation arm. And their primary endpoints were usually freedom from non-fatal and fatal ischemic stroke. Next slide. Again, you can see around 60% distribution, randomization was in men, and lowish comorbidity status. Atrial septal aneurysms were present in approximately 30-ish% of patients, and large right to left shunts were randomized mostly in the CLOSE study, and they went big guns and randomized 90 to 94%. Patients were large right to left shunts, and that is important as well, because currently we do PFO closure independent of shunt size, but CLOSE looked at patients specifically with large right to left shunts. Continue, please. So these are the endpoints, and you can see that recurrent strokes were lower in the device-related arms, but also technical success was high and procedural success was high in all of the three trials. Just carry on for me. Side effects, again, serious adverse events, sorry. Again, procedural related and atrial fibrillation take the center stage for those, but also major bleeding, as I mentioned, access related complications. And I'll talk you through why that would be the case later on. Carry on, please. So how does that translate into our guidelines? So the European position paper in 2018, which is kind of reflective of our European Society of Cardiology standpoint on this, says that you should perform PFO closure in carefully selected patients from 18 to 65 years with confirmed cryptogenic stroke, TIA, or systemic embolism, an estimated high probability of a causal role of PFO. And they advise using clinical, anatomic, and imaging features to determine that. Now, it's important that they mention TIA as well. Carry on. So looking at NICE and our national guidance, now it's quite outdated. It was last produced in 2013. Keep going, please. But they have said that the optimal treatment with PFO, patients with PFO, although it remains undefined, they have considered this procedure can be used with normal arrangements for clinical governance, consent and audit, and that it should only really be performed in centres where there is cardiac surgery support, and that is because of the complications that can occur. And in particular, the cardiac surgery is there for bleeding complications around the heart, so tamponade, and for device-related complications, and specifically embolization of the device during the procedure. Usually if the device embolizes to the left side of the heart, that's an urgent indication for cardiac surgery. They said the evidence of its efficacy is adequate, and they mandate that all the information from the procedures is entered into the cardiac audit database. Next slide. The British Medical Journal last released an opinion in 2018, and they said it was a strong indication in whom patients in whom anticoagulation is contraindicated or declined, and you can provide PFO closure and antiplatelet therapy versus antiplatelet therapy alone. Next slide. The American Heart Association is more aligned with the European position in that in patients who have stroke at a young age, a non-lacunar stroke of undetermined cause, despite a thorough evaluation, and there's a PFO with high-risk anatomic features, they recommend that it's reasonable to choose closure and long-term antiplatelet therapy over just antiplatelet therapy alone. Next slide. So overall, where do we stand? So the NHS England position statement is that they have reviewed the evidence and they've concluded that there is enough evidence to make the treatment available. Next slide. The way that it is available is through commissioning through evaluation. So that's an ongoing assessment process where certain centres are funded to give treatments that are not routinely funded by the NHS, but have shown some potential significant benefit. MFT, or Manchester University Foundation Trust, is one of those commissioned centres, but their caveat is that the treatment should be offered in a limited time frame so that clinical and patient experience data can be collected, and that can form ongoing evaluation programs to inform funding decisions. Next slide, please. And their commission criteria is that PFO closure can be commissioned for adults around the age of 60 years and under who've suffered an ischemic stroke or TIA with brain imaging abnormalities. And importantly, they say that it should be due to paradoxical embolism. Next slide. So they've mentioned ischemic stroke or TIA, but we know that the TIAs are not always clear-cut events, and especially in the younger people, when there's no MR footprint, you really have to assess this on a case-to-case basis. And for us, it's usually when there is no other explanation for the event other than a PFO, and that is what they recommend. But they also recommend a very thorough evaluation for the presence of other stroke risk factors such as hypertension, vascular disease, AF, and smoking. Next slide, please. So how do they recommend that we find out that there's a PFO? So they recommend bubble contrast transthoracic echo, which includes provocative maneuvers to open the PFO. Often during the bubble echo, the shunt will not be apparent at rest. And so you have to really kind of be quite strict with the Valsalvas and the provocative maneuvers. But the other option that they give is if there's a strong index of suspicion, even if the bubble echo is negative, you can do a transesophageal bubble echocardiogram, and we in reality will combine that with a femoral vein injection of agitated saline as well. And just because we will insert a catheter right next to the septum and inject agitated saline on the septum to allow us to visualize the bubbles as closely as possible to the septum, rather than through a vein in the arm. And they've also recommended that bubble contrast transcranial Doppler can be used. Clinically, they've mentioned that clinically significant PFOs, so those with moderate to large shunts and those with atrial septal aneurysms, are more likely to have caused an ischemic stroke. Next slide, please. So this slide summarizes the criteria for closure. So a stroke or TIA, clinical and imaging evidence to support this diagnosis, and then a clinically significant shunt or atrial septal aneurysm on the bubble echo. But importantly, we have to make sure that there are no other risk factors that could have caused the stroke. And then those patients are discussed. Every patient, sorry, I've just lost my slide. Every patient should be discussed at an MDT, and that MDT process should involve a stroke clinician and an interventional cardiologist. Our MDT also has an imaging cardiologist as well, and 2 stroke physicians, and previously 2 implanting cardiologists, but I've just lost my partner, so it's just me, and around age 60 years or under as per the clinical trial criteria. Next slide. So in reality, how does that occur for yourselves in the other hospitals that aren't but with patients who aren't at MFT? So we have a dedicated email address for referrals to be sent through to, and that is checked on a weekly basis. Next slide, please. And we ask everyone to fill in a referral pro forma, and this has been specifically designed so that we can use the information to discuss the patients in MDT. I'm sure most of you will have seen this pro forma. There are plans to actually build a database so that you're not having to write in or type in things to a pro forma, and you can just enter things like you would on a CAT system that we have for referral of patients for angiography, similar to that, but it's still in the infancy of it being used. So for now, we're sticking to the pro forma. Next slide. And the pro forma kind of directs you to have either CT or MRI brain imaging, and then brain vessel imaging, and that can be in the form of carotid Dopplers, CT angiography, MR angiography, bubble echoes or transcranial Dopplers, heart rhythm monitoring, and we will accept a minimum of a 24-hour tape. But you know, there are obviously patients that have loop recorders in at the other end of the spectrum. And then importantly, we do require a thrombophily screen. We acknowledge that not every hospital has access to a thrombophilia screen, and samples have to be sent away. And if it's proving difficult, then just mention that on the pro forma and we will arrange the thrombophilia screen at MFT. Next slide. So once we receive the referral, it's scanned onto our electronic patient record system, which we call Hive, and it is then triaged by myself. And if we are happy with the referral and the bundle is complete, so there is an admin person that is scanning the referrals onto Hive. And at present, because the service has got such high demand, we are only scanning on referrals that we think we have enough information available to be discussed at MDT. And so those referrals are scanned on and triaged by myself and listed for the MDT. We then require all the bubble echo echocardiogram images to be sent through. And this is a new part of the patient pathway that has only been introduced at the beginning of April. So you may find that some referrals that you're sending through, you may get an email back to ask you to transfer the bubble echocardiogram images over. If that's proving difficult, we have people at MFT who can request the bubble echo images. And then at the MDT, we will review the clinical history, the investigations, and actually review the pictures of the bubble echocardiogram, and then discuss and a decision is made. The reason that we've been so strict with getting bubble echocardiograms now is that we're finding some people coming through who have not had, who may have had bubbles seen, but these are late or not significant, or from the previous breath being taken, from the previous cardiac cycle. So for that reason, in order to filter out patients who definitely don't need PFO closure, we've now decided to review all bubble echocardiograms at the MDT. And it is also because a lot of hospitals don't have a standardized way of reporting bubble echocardiograms. And this just helps us to have a look. And sometimes we will repeat that bubble echocardiogram. Sometimes it will be borderline, and we will refer them on for a transesophageal echocardiogram. Next slide, please. So as I said, once we've got the actions from MDT, we will write back to you to let you know what the outcome of the MDT is. And if they need listing, they will be listed. Next slide, please. The other outcomes, if they're not accepted straight away for the procedure, are that they don't meet criteria for closure. For those patients, we will always offer them a clinic appointment to discuss why they're not appropriate for closure. So when I send out the MDT outcome letter, I have a paragraph at the bottom to say, if you wish to discuss further, then call my secretary's number and we'll arrange an appointment for you to discuss that directly with me. And then there's a third lot of patients, and these are usually the TIA type patients who fall into a grey area, where our stroke physicians aren't entirely convinced that it's a TIA, or there's other risk factors, and it needs to be discussed together. And for those, we make a shared decision-making outcome where we invite them to clinic, and I have a direct conversation with them about what was discussed in MDT and what their concerns are and expectations are, and what the procedural risks are, and what the procedure and how much benefit they may gain from the procedure. And together we have an informed conversation and come to a decision about whether they would like to be listed for PFO closure or whether they would like to continue on medical therapy. Next slide, please. So prior to the procedure, they will all be, and this is also a new step in the pathway, they will all speak to me prior to the procedure. Now, my predecessor, because of the waiting list demands, wrote them a letter and gave them the option of making a clinic appointment. But recently we've had a few people through who've expressed that they would have liked to have spoken to me before the procedure, but didn't feel that they could ring the number and ask for an appointment. And so we've now standardized it and said that everyone who's listed for PFO closure will have a conversation with myself beforehand, and I will talk them through the procedure, and then they will go to their pre-op visit where the nurse will then again talk them through the procedure and do the pre-op tests. And those, usually that just involves standard blood tests, including full count and U&Es, but also COVID swab them and MRSA swab them, and then we will offer them a date for the procedure. Next slide, please. So on the day of the procedure, we go through the consent on the morning of the procedure, and we talk them through the fact that it is partly a diagnostic procedure. A lot of people who've got clear-cut bubble echocardiograms that signify a shunt will come to the procedure without a transesophageal echocardiogram, and that we inform them that there is a 1 in 10 hit rate of there being a false positive bubble study, in which case our intracardiac echo will be used to locate a PFO, but if we don't locate the PFO, then the procedure will be stopped at that point. If we don't find a PFO, we usually do a bubble study inside on the septum and also a contrast injection on the septum to make sure that there is definitely no shunt that we can see. In 9 out of 10 people, we do find a patent foramen ovale, and we then go ahead using ice to close that. Now, the common risks that we consent them for are bleeding, bruising, pain, scar, infection, damage to the blood vessels in the groin, and arrhythmias, including atrial fibrillation. We also mentioned the serious and infrequent risks such as heart attack and stroke, which are both caused by us dislodging clots inside the heart. And if that clot goes to the coronaries, it causes a heart attack. If it goes up to the brain, as you know, it will cause a stroke. The way that we reduce that risk is we give them heparin during the procedure, which is weight adjusted, and we also ask them to continue their clopidogrel up until the procedure. So even on the day of the procedure, they will take their, usually in most patients, clopidogrel, but whatever antiplatelet or anticoagulant they're on. If there is a serious complication during the procedure, we say that we have the option of cardiac surgery on site. The risk of that is around 1 in 500. And there is also a small risk of an allergic reaction. Device-related risks. So we give the device approximately 2 years to close the shunt, the PFO, but we say that after that, if there is a residual shunt present, we call that device failure. Very rarely the device can become infected, so we give them antibiotics during the procedure intravenously, but also give them precautionary advice about antibiotics for dental procedures and avoiding things like tattoos for the first 6 months. As I mentioned previously, very rarely the device can embolize. If it embolizes into the right side of the heart, we can usually retrieve it with snares, but if it embolizes to the left side of the heart, that's usually a case for cardiac surgery. After the procedure, between weeks 2 and 10, we warn patients that they may experience some chest pain and funny heart rhythms. And we say if there's anything untoward, to go to your local ED to get an ECG or contact us at MFT. Very rarely the devices can make patients who are migraine sufferers suffer worsening migraines. And this is particularly in the first 6 weeks. So for migraine sufferers, I always add on aspirin because there is a theory that those migraines are increased because of the microclots caused by the device being placed in the heart. Next slide. So for the procedure, we usually insert 2 9 French sheaths into the right femoral vein. Through one sheath, we put our intracardiac echo, and through the other sheath or tube, we put our equipment. Usually we put a balloon, put a wire across the PFO when it's been identified and measure the size with a balloon. And then the device, as you can see, is made up of 2 discs, which are made of nitinol, and a disc goes on each side of the PFO. We make sure that we test stability to make sure that it doesn't move out of place before we release the device. And we put a Z suture in for closure. They are told to lie flat for 4 hours and then they're mobilized and discharged on the same day. Okay. So essentially when the procedure is done, we will do a report and do a discharge summary to the GP, but every patient should receive a letter to the referring stroke physician. So every patient has a letter sent to their referring stroke physician so that you know what the outcome of the procedure is. Next slide. I can't see a slide. Yeah, next slide. And then after the procedure, we do a baseline 6-week transthoracic echo, and I will follow them up with the results of that transthoracic echo. And at 6 months, we do a bubble echo, and that's because we expect the majority of shunts to have sealed within that 6-month period. And we anticipate then that once the shunt has sealed, that we were able to discharge the patient at that point. But if for whatever reason that shunt hasn't sealed, then we do 6 monthly bubble echocardiograms until they get to 2 years, at which point we do a bubble TOE to have a look at why the shunt has not sealed and whether it's anatomical or there is another shunt or the device isn't sat properly. Next. This is my last slide, and it's just so you know, there aren't that many commissioned centres in the UK for PFO closure, but we are one of them. And the last national data that we have showed that we were the second largest centre. So we do a lot of these procedures, and we have very good data on our complication rates, which are very low, less than 1%. And you know, I guess it's just to reassure you that, you know, it's the right thing to do to refer them. We have quite a robust process to get them to the point where they have PFO closure, and that is forever being changed and advanced and made better. Next slide. That's the end slide, I think. So thank you for listening. Sarah, I don't know if you want me to take questions now or...
Yes, I think we do. So first question was just around the confirmation of the email address. As I said, we've got some information on our website, and I think we've got a specific person's name. So I don't know if you maybe wanted to either post that in the chat whilst Amit's speaking, just to confirm that. That would be really handy. Yeah, and then there's another question from Dr Raymond, who's at Wigan Stroke Unit. He said, when consenting for the procedure, what are the risk reduction figures that you quote, i.e. risk of recurrence of stroke per year versus reduction in risk post-procedure? So that's in the chat if that was too quick.
Yeah, so if they asked, so we do explain to them that the data that we have and the evidence that we have shows a stroke risk reduction, but because there's so much variability between trials, we don't quote specific figures unless they ask. If they do ask, we go by the meta-analysis figures, which are that over a median of 6 years, there is a 3.3% risk reduction in PFO closure device groups compared to therapy alone.
Fabulous. And then there's another question, which is, what is the waiting list at the moment?
So waiting list at the moment is 6 months, but we are putting on a lot of extra lists. It was 9 months, so we've got it down. But
chipping away.
Yeah,
I think you outlined, didn't you? You've had some staffing issues just in terms of colleagues to support you, etc. So hopefully that will resolve itself a little bit. Fabulous. Well, we'll have a little time hopefully at the end for a few any other questions. So if you've got anything else you want to ask, then put your thinking caps on and we'll come back. I'll move now on to Dr Amit Kishore.
Thanks, Ferrah. It's a fabulous sort of summary. I'll be complementing what Ferrah said by talking about the transcranial Doppler services, which we've started at Salford over the past year or so. I attend the PFO MDTs whenever it's run along with Ferrah. So one of the reasons why we started the transcranial Doppler services was the delays in getting our bubble contrast echoes done at Salford, and we run the ESUS clinic here. And part of investigating a cryptogenic or embolic stroke of uncertain source patients, ischemic stroke or TI patients, would be to evaluate for PFO, particularly the patients who are younger. And we, after the pandemic, we noted that the echo with bubble contrast requests getting delayed for about 9 months, and we had to find ways to screen patients for PFO. And over the last year or so, we've started the TCT clinic. And I'll just talk briefly about TCT. I've got about 15-20 minutes to talk about this procedure. So the basic principle of a transcranial Doppler is it's an ultrasound technique, and the probe is about 2 megahertz, and it measures the blood flow velocity in cerebral arteries. It uses a low frequency transducer and is placed on the temporal bone. And historically, the probe can be positioned in different parts of the brain, including the orbital area, to locate different vessels from vertebral arteries, posterior cerebral arteries. The purpose of this talk is just about the middle cerebral artery. And the thing about the TCT is it allows for a non-invasive assessment of cerebral hemodynamics and also a functional assessment of a shunt significance. Now, this is important because when you do a bubble contrast echo, you're looking at the shunt from a location perspective, but how much of it is clinically significant is not known. But when you actually hear and see the bubbles through a transcranial Doppler, you immediately know that they are going to be significant because these bubbles are passing into the brain. So a shunt, which is there, is likely to be significant in the context of somebody having had an ischemic stroke. So, so what's the role of the TCD in bubble detection, in PFO detection? And the idea is to detect the right-left shunt by monitoring cerebral microemboli, which you can hear and see on the monitor of the Doppler machine. And you inject, very similar to the echo, you inject agitated saline into the peripheral vein, and you can hear and see the PFO. You can see the microbubbles crossing across PFO, and these appear as high-intensity transient signals. I'll show them later on. Now, clinically, why is this relevant? Because the recent guidance, the NCG guidance for stroke in 2023 suggested that, as Ferrah had mentioned, that around the age of 60 years, that people who have had an ischemic stroke or TIA of an undetermined etiology should be considered for device closure. And this is within 6 months. I'm not sure if Ferrah mentioned it, but the time frame that has been given is 6 months of stroke. So I don't know when the clock should start here, whether this is after somebody meets the diagnosis of a cryptogenic stroke or an ESIS, but they've not clearly mentioned that. But in essence, once you label somebody as a cryptogenic stroke, then that clock should start and the closure should happen within 6 months. So in our center, as I said before, there was a waiting period of about 9 months in the last, although I think that's getting better according to to Peter, who's on the Teams meeting here. But even then, we're still waiting for about 6 months or so for a contrast echo to happen. So how good is the transcranial Doppler? And so this is a paper which is being published in the last 5 years or so, which had done a consensus statement on screening tools for diagnosing PFO. And this is a European consensus statement, and within that statement, they had a meta-analysis of all the techniques which are used to screen. So the two techniques commonly used for screening which are non-invasive, are the bubble contrast transthoracic echo and the bubble contrast transcranial Doppler. And as you can see, a number of studies have looked at both, but largely, when I looked at them, they appear to be quite poor quality. But overall, the sensitivity and specificity appear to be much better with the transcranial Doppler than with a transthoracic echo. So you can see the sensitivity is about 95% with the TCD, and the specificity is about 92%. The C statistic, which is a diagnostic accuracy test, you want it close to 1. Again, is high for transcranial Doppler compared to a TTE, which has got a much lower specificity as well as sensitivity. So to me, TCDs are it's a powerful tool. It's a bedside tool. It can be used for screening, definitely for stroke patients, either as an inpatient or an outpatient. With contrast TTEs, it's more difficult to do it within, in hospital settings. There's no obvious gold standard, in my opinion. I think the TOE is there. I think it's very useful to confirm the presence of and to look at the structure of the heart. But the sensitivity of TOE, again, for a screening purpose, is only about 8-9%. And in my opinion, I think we should be using multiple imaging techniques to confirm or refute the presence of PFO. So do not stick to just a contrast TTE. If you still feel that a PFO is relevant in a young patient with no other risk factors, please proceed to either doing a femoral contrast TTE or a TOE. And we should not be stopping at one single screening procedure. So that's the pathway which is being put up by the European Congress committees. And I think the advantages, as I talked about, is pretty simple. It's accurate, reliable, it's cost-effective and safe. It's an excellent non-invasive test, and it's particularly reliable when you're looking at very small shunts, and it's better than TE in that circumstance. It's got excellent sensitivity and specificity. So the machine which I use here the last year or so is this particular machine called the multi-top digital machine. It's the company is DWL. It's a German company, and the way I got the funding for this is through a grant from Abbott as a quality improvement project, and partly funded by the trust as well. It costs about £25,000, this particular device, and in essence, it's the patient can be either supine or in a sitting position. And it's bilateral TCD monitoring using probes on either side. These are handle probes. And I've got a headset as well to fix it. So I don't need an additional person to inject the bubbles. And the idea is to do it in at least 2 phases. One is at rest, and the other one is at Valsalva. You can also introduce a cough in between, and you categorize the PFO into different levels. And then you need to look at the latency from when the bubbles arise. So in essence, you would need to. Sorry, I'm just going to try and see if I can move this slide. It's not moving. Right. So in essence, when the probe goes onto the temporal window and it you identify the MCA, the screen looks like what it shows there on the right side. And if you can see the curtain-like showers there on the right side, these are the high intensity transient signals. So you can actually hear them and see them on the monitor. I've just got a quick clip here on just looking at what the process looks like. I'm not going to go through the full set of.
No, I don't think we can hear the sound to that.
You can't hear the sound to that.
I think, did you enable the sound when you shared your slides?
Okay, just give me 1 minute. Let me just get that back then.
Take a deep breath in.
Can you hear that now?
Hold that and bear
Yeah,
down
that's
with your
great.
belly. Push hard. Push, 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 push. Breathe normal. After I saw the effect of the Valsalva and we able to again do a perfect Valsalva maneuver, we are ready for the injection. I'm going to watch the timer on the TCD machine. I will try to inject it at 0, so at least I know exactly how long I see bubbles. So 5, 4, 3, 2, 1. I'm injecting. Please lift up your arm and pump your fist. Pump your fist, pump your fist. Take a deep breath in. Hold it. Bear down. Push, 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 push. Breathe normal. Breathe normal, relax. This was a negative PFO test because we did not see any bubbles arriving to the brain at 30 seconds.
So if you, I'm just going to try and get this one up here, if you can hear this. So I'm going to repeat that again. So that was a negative test, but if you actually hear a positive test, you can hear the high intensity trends. It's not very, this is the best video I could actually get from my own machine, but you can hear the sort of pings which are happening, which are the high intensity transient signals.
Thank you so much.
So in terms of categorizing how significant the PFO is, to me, I think if I hear or see any of the bubbles which pass through, they are significant, but there is a grading system which you could use. So you can grade it as 1 to 4. And the pictures on the right side actually show what the significant of a PFO shunt is based on the grading. So a grade 4 is a shower, which usually indicates a very significant and clinically relevant PFO. So I think the things to contemplate when I've been doing this now for about a year or so is that there are some patients who you don't get a temporal window. So that may be either user dependent, or sometimes it could be the structural variation in the anatomy, which might prevent us from getting a window. Equally, you would also, when you refer somebody for the PFO MDT for doing TCD, then you would probably need to have a structural image of the heart prior to the referral, because it's important to see if there's no other source of embolism like dilated cardiomyopathies, and which you can't see with the TCD. You don't need a bubble contrast. Then it's just a plain transthoracic echo, which hopefully will be quicker. I cannot visualize obviously extra cardiac shunts, but if there is a significant delay for the bubble arriving, usually there's a latency period of about 5 to 10 seconds for the bubbles to arrive. And if there's anything more than 12 to 15 seconds, then it could be an extra cardiac shunt. But again, that needs a lot of practice to pick up. The other things which I have also noticed is that you probably get better amount of microbubbles when you actually sit upright, or at least at 45 degrees. It depends on the size of the cannula. You need at least a pink gauge, and you need to have a proper Valsalva maneuver as shown in that video. So that the size of the wave which you see should drop by about half. And you need to be quite diligent, and you need to have repeated testing. So in Salford, we've got our own sort of QRG, quick reference guide, and we've also got patient information sheets, which we share with patients. For us, we screen patients who are under the age of 60, around the age of 60, with a modified Rankin score of less than 3. And if at the minute what we're doing is, if the TCD with a bubble contrast is positive, we refer directly to a PFO closure MDT, along with the transthoracic echo and the rest of whatever Ferrah has asked and said. If I'm struggling to identify the shunt on the TCD, then we request for a TT with bubble contrast as well. And obviously the patient comes to see me in the ESUS clinic. So as of now, I've done about 30 patients or so over the last 8 years. So I've got about 25% positivity. I know in cryptogenic strokes it's a lot higher. It's about 40 to 50%, but it's about 25% here. I've not had a false negative as yet, and I've yet to hear back from Ferrah about any of the false positive ones when she's had a look at them in theatre. So I think to summarize, it is a sensitive tool. It can quantify the burden of PFO-associated embolism. It should complement the other forms of imaging, including the TOE. I plan to make the referral streamlined and make a request so that clinicians in Salford can request this procedure on the electronic patient records. I'd hope to actually quantify the amount we're doing over time, and there needs to be some audit standards. There's potential to use the TCD beyond just the PFO closure, check for vasospasms. You could look at intracranial disease. So there's potential to use the TCD machines. And more recent data is coming out that even patients over the age of 60 seem to be benefiting, in fact, more than younger patients. So perhaps it could be used as a research tool as well in the future. I think that's it, really. Any questions? I'm happy to take any questions.
I don't have any questions in the question boxes. I don't know if anybody wants to either raise their hand or whether they want to stick anything in the question box. Don't know if you had any comeback or comment on that, Ferrah.
Not really, just a 6-month waiting. We obviously, in an ideal world, you'd get it all done within 6 months, but no centres are achieving that at the moment because of the delays that have been described. But as we streamline the process, we'd hope that we could achieve that.
Excellent. You had a couple of questions, didn't you, in the chat? What's the smallest size of shunt on bubble echo that is considered significant?
So
I think you've answered that.
Small is less than 5, but anyone that has any bubbles crossing within the first 3 cardiac cycles, we will accept. And if we think that we need to do a femoral vein bubble echo or a TOE bubble echo, we will do that at MFT. And because sometimes you just can't get the Valsalva right, and so you may not be able to open that flap properly and get the right amount of bubbles through.
Excellent. Okay, so I'm conscious of time. So just to summarise then, so we do have a service at MFT, currently operating on yourself, but with plans to expand that. and that we need to be identifying patients, picking them out and referring them. We've got the information about how to refer, which we will circulate with the slides, and we will also make sure it's on our website. Check the chat function, there's information there. We've got a web page dedicated to PFO. And I will edit out all of the gremlins for today. So tomorrow, so if you were to review the video, it just would be as if it never happened. And I'd like to thank our speakers today, and I'm sure that if you've got any further questions, that they'd be happy to answer them via email. I've just spotted there might be an extra question. No, I think we've answered all that. Oh, Dr Amit, is there any, this is from one of your colleagues, is there any plans to introduce formal training for TCD to improve capacity and access?
Sorry, I missed that.
This is from Jay and your team. Is there any plan to introduce formal training for TCD to improve capacity and access?
Yeah, I mean, this is something we plan to run with the help of the company itself. So it probably needs discussion as to how many people will be able to do it, and I think it should be done by. I think it's a very simple, non-invasive test. It should be a bedside test. It should be done by as many people as possible, really, to reduce the burden from cardiac services. And so yes, I think we should be doing it more often, the training.
Excellent. And any final comments from you, Ferrah?
So I just wanted to say that if anyone wants to come and watch the procedure, to be able to give their patients a bit more detail about what is involved, then just drop me an email. Sarah has my email, so she can circulate that, and I'm happy to arrange that, just so you can have a more informed conversation with your patients.
I've just popped it in the chat, so people should be able to see that. So no, that's a great offer. So apologies for starting a little bit late and finishing a tiny bit late. I hope you enjoyed it. As I said, it'll be uploaded to our YouTube channel next week, and we'll send an email out with slides, etc. as well. So have a good weekend, everybody, and thank you. Goodbye.
Thanks. Goodbye.